Colorado, Harold Cudler, who was at the VA for many years, and Donald Kolish, who was a primary care, a family doctor in rural New Hampshire, and also worked in the VA as a primary care physician. I just want to set the stage, and then I'm really going to I'm going to be quiet because I'm so excited to hear what other people have to say. But we have long faced a crisis in rural health, and this is particularly impacts veterans because between 20 and 25% of veterans live in rural and remote rural areas. And we have we had a crisis before COVID, and COVID made the crisis into more or less a disaster. And the context of this really today is that we are facing in the next couple of weeks an even more serious crisis because the VA secretary, under the Mission Act requirements, the VA Mission Act of 2018, required an Asset and Infrastructure Review Commission to look at which VA facilities to close, improve, repurpose, or consolidate. And the secretary will be compiling what really is a hit list, and they are already having meetings all over the country. I just listened in on one this morning, and there will be serious closures and changes in the VA that will be recommended, and many of them, at least a fair number of them, will affect rural facilities. So this is an extremely timely discussion. Veterans who expect the VA to serve them will find it in some instances more difficult, and it will put more strain on an overstrained civilian sector system. But I really don't want to talk too much because I really want to turn the proceedings over to our incredible group of panelists who have so much expertise in this area. And Mark Deutschman from the University of Colorado, who runs the university's rural medicine track, is going to try to set the stage for you about what is really going on in rural America. And so I'm just going to turn this over to Mark.
Thank you very much, Suzanne, and thanks to the fellow presenters and those in attendance. My job is really to sort of talk about some more background about rural healthcare. And I have a few slides that will hopefully help with that. I assume that you can see my slides okay. Can you get a nod from somebody? Okay, good. I'm basically going to talk about rural healthcare and access to it. The objectives are to start out with some definitions and facts, to talk a little bit about how the healthcare system is structured in rural areas, and really what the purpose of the rural healthcare system is, and talk about some unique features of rural life that impact healthcare, and then provide some advice to individuals seeking healthcare in a rural community. So there are various definitions of urban, and there's also a definition of frontier, and everything else is rural. The problem is that the US Census Bureau has a different definition of rural than the Office of Management and Budget. So really rural can mean different things to different people. But I think the basic bottom line is that I think most of us know that when you are in a rural area, you have less access to things that are found in urban areas, which includes not only shopping and cultural events, but also healthcare is different in rural than it is in urban areas. So I'm going to be using Colorado, where I am located, as an example, but it's typical of a number of other states. Colorado is 2/3 rural or frontier. And as I mentioned in the previous slide, frontier means fewer than 6 people per square mile. So that's pretty sparse. And if you look at this map, the dark blue is frontier areas of Colorado and the lighter blue is rural. And the only areas that are really urban are this area in the middle of the state and then way over in Mesa County on the left. So Colorado is a very rural state. And rural areas differ greatly from one another. They differ by geography and topography, and mountains, rivers, and weather have a great deal of impact on people's ability to travel for healthcare and for other things. There are also different population groups in many of these rural areas. We often think of rural as being not diverse, but actually many rural areas are quite diverse with immigrant populations that have come for agricultural work and everything else. Rural areas also differ in their social structure and culture, and of course, in their economics. So just to do a little comparison of several demographic factors of rural versus urban, rural populations tend to be older in median age than urban populations. They tend to have lower household income. And in Colorado, this is quite significant, as you can see from the figures there. There's more child poverty. There are more people who are uninsured or underinsured, especially some of the self-employed agricultural people are self-insured or choose very low premium plans, which leave them underinsured. Suicide rates are higher in rural communities. That may have something to do with the access to firearms. Motor vehicle deaths are higher, and that can be impacted by distance to care. Teenage pregnancy rates are higher. And actually, especially in Colorado, health insurance is actually more expensive in rural communities than in urban communities. So that's a little bit of background, but some additional points that are important are what are the healthcare facilities that are available in rural communities? Well, many of the hospitals that are in rural communities are called critical access hospitals. This is a special designation according to Medicare. These hospitals are 25 beds or fewer, and some of their beds may be used as basically nursing home beds or rehab beds. So they're not all acute care beds. They have an average length of stay of no more than 4 days, which means that they don't usually keep people who are have a high level of need and are very sick. Maybe some of them do not have intensive care units. They do, however, have written agreements with other larger facilities where they can transfer people who need a higher level of care. They are generally quite well equipped, and they are generally quite well staffed to provide a broad range of essential services, especially primary care, as well as emergency and routine medical and surgical services. So these are generally quite good hospitals. They're just small and have a limited capacity. Then in terms of ambulatory care, many of the clinics are called rural health clinics. Again, this is a designation that provides for clinics that are located in a non-urbanized area that is a shortage area, and they are noted for also including advanced practice providers like PAs and nurse practitioners. And they may be private, they may be affiliated with a federally qualified health center, and they also may be operated by a hospital. And there are many rural hospitals that have an affiliated rural health clinic. So again, just using Colorado as an example, if you look at this map, all the blue counties are the frontier counties, and you can see that in almost every frontier county, there's a Red Cross, which is a critical access hospital. And most of them have at least one rural health clinic. But as you can see, for example, looking up in Moffat County here, there's one hospital and a number of clinics, but they're all over in one side of the state. And so people that live in another part of the state may have up to a several hour drive to a clinic or hospital. So you can see they're scattered about the state, and most states, especially predominantly rural states, do have these critical access hospitals and rural health clinics. I would like to emphasize that the purpose of the rural healthcare system is really to provide access to primary care, which of course everyone needs access to, and also to provide access to some subspecialty services, again, depending on the population size and the geographic barriers. If a rural community and hospital is located separated by a mountain range or a river or a lot of weather, it's likely to have more resources than a place that is much more accessible to a larger center. But I think the main thing besides accessing primary care and some specialty care is that these facilities really do establish a pathway to services that are not available locally. So they have these transfer agreements, and they have consultation agreements with larger facilities so that they can readily transfer patients who require a more complex level of care. And hopefully also are very expert at getting information back from these other larger places so that the person can continue getting their follow-up care and primary care back home again. So it's worth noting that a hospital in a rural community is usually one of the 3 largest employees in that community. The 3 largest employees are usually the school system, the local government, the hospital, and then usually maybe one industry. But it really is a large economic contributor to any rural community. The other concept that I want to introduce is the concept of a HPSA, or a health professional shortage areas. These are areas that are designated as being short of either primary care, oral health care, or mental health. And the thresholds which qualify an area as health professional are shown in this slide in terms of the ratio of population to the healthcare provider type. And again, getting back to Colorado, which is the best example I can provide, if you look at Colorado, every community that is in a color is considered a health professional shortage area for primary care. So you can see that except in the major urban areas with Denver and Fort Collins down to Pueblo, almost the entire state is a primary care health professional shortage area. And then if you look for mental health, it's even more dramatic, that almost the entire state, except for the major urbanized center, is considered a mental health shortage area. And then if you look for oral health for dental, again, it's pretty much the same as primary care. There's quite a shortage of dental services in almost all of the state, except for the major urban areas. So I'm going to come to near a close here by bringing about a discussion of some features of rural life that anyone who lives in a rural area is probably quite familiar with, but those people who move to a rural community from an urban community may be surprised about. One is that people often wear many hats. I was a rural physician for many years, and in addition to my clinical practice, I was on the fire department and was also a director of the ambulance service for 2 counties. So people have many, many hats, and it's common for people to be employed by more than one employer. People also have multi-level relationships. Their friends may be their customers. Their patients may be their friend, etc. So people learn to balance these relationships that are multi-level. People in rural communities also understand that they're going to be driving longer for things that are not located there, shopping, entertainment, etc. The fire departments may be staffed by volunteers, and so the response time may be significantly more than there is in an urban area. And rural people often consider themselves and exhibit more independence and self-reliance. And for healthcare, that often means coming into care later than they might in the city. These same features impact healthcare. So limited access to things that require large populations, and that predominantly is represented in the need to travel elsewhere for subspecialty care or obtain that care by telehealth rather than in person. So the travel distances, same thing that applies to shopping and cultural events applies to healthcare. People in rural communities understand that they're going to have to travel. The fact that rural populations are older means that there may be higher demands on the healthcare system because older people essentially access healthcare more. And then there are location-specific health risks. The place where I practiced was a logging community, and we had, injuries from trees falling on people and getting cut with chainsaws and stuff like that. Then so agricultural areas, as you know, agriculture, mining, and forestry are the most dangerous occupations in the country. And so there are unique hazards to people. There may be pesticide and fertilizer issues in the water system. There may be different things that relate to the economy of the area. And just like I said on the other slide, that the fire department may be a volunteer department. Well, guess what? The ambulance service is a volunteer ambulance service. And so if you call an ambulance, there isn't somebody waiting there to hop in the ambulance. Somebody has to go from their place of work to the ambulance shed and start the ambulance and start it up and drive to where the help is needed. So these are things that come naturally with rural life. So I will sum this up by saying that my advice to anyone who lives in a rural community, especially somebody who's a newcomer, is to find out what is and what is not available locally. If it's not there, it's probably not going to be there when you ask for it. So you need to be aware of what's available, and especially to establish care locally so that you are known and that you know the people who you may need services from, because that will facilitate your access to care as time goes on. So I'm summing up with just a picture of a nice rural clinic in Center, Colorado, and I will stop and yield the time to others.
Thank you. Thank you. So I'm gonna pass the baton to Harold Cudler, but I do want to make a couple of points. And actually, I want to ask you one other question, Mark. How hard is it to recruit physicians, nurses, and other healthcare professionals to rural areas?
Well, that's one of the reasons why most of these areas are health professional shortage areas, because there is some problem recruiting. It often takes a year or so to recruit, for example, a family physician to a rural community, and it can take even longer for any sort of subspecialists. So that is a problem. The program that I run emphasizes finding people who came from rural areas and helping them during their training so that they can return. But you're right, it is not only recruitment, but retention.
Yes. So I think that you said that you had advice to people who live in rural areas about to find out what is and what is not available locally. And I think the same advice can be given to policymakers, VSO representatives, and legislators that, there was an assumption in the Mission Act that there would somehow be services available in rural areas that just aren't there. And, we have study after study that shows that people will have to drive. I mean, it doesn't matter whether you're going to the VA or not. The advantage of the VA, of course, is that they do the driving for you and pay for your stay. I do want to I do want to encourage everybody to look at the chat. Mark introduced me, sadly, I didn't know about them before, to these HPSA maps. They're also available. There are also state maps. And, you know, before anybody makes a policy decision about closing a VA facility, they really ought to check out these HPSA maps. And because it, you know, a picture is worth 1,000 words. So, but we also have a lot more words, which are probably worth 1,000 pictures, coming from Harold Cudler and Donald Kolish. So I'm going to turn it over to Harold Cudler, who is, will talk really about the mental health situation in rural areas. Harold, I'm thrilled that you're with us again, and we're looking forward to hearing from you.
Well, thank you, Suzanne, and I hope you can see my slides. Okay, so you know, so I'm going to drill down both to mental health and rural veterans in order to complement the things that Mark talked about. And the same principles apply, but the numbers can change a little bit. And a lot of this is gained from my experience for about 10 years as the coordinator for mental health services for a 3-state region that included North Carolina, almost all of Virginia, except for Northern Virginia around DC, and a little bit of West Virginia. So let's take it from there. This is actually a picture from West Virginia. It was given to me by Hilda Hetty, one of the people who woke me up to the whole issue of rural health. And this is not an unusual kind of sight to see in rural America. There are good reasons why. If we look at the demographics of rural veterans, 4.7 million of the nation's 19.2 million veterans are rural. That's 24% of all veterans are rural. That's a bit more than the 20% for the total US population. 58% of rural veterans are enrolled in VA healthcare versus only 37% of urban veterans, which kind of shows you that rural veterans really rely on VA because I think they can't get these services in their community. 7% of enrolled rural veterans are women, which is about equal to the national percentage of enrolled women veterans, a percentage, by the way, which is rising quickly as more women are serving in the military and in combat areas. 13% of enrolled rural veterans are minorities, while minority veterans make up about 23% of the veteran population. So they may be underrepresented, and that's something that's probably worth some study. And 49% of enrolled rural veterans earn less than $35,000 a year, which is not the poverty level, but it's not a lot of money. And it's something worth considering. There are challenges faced by rural veterans, and Mark responded to a number of them, and some are specific to veterans. Like any rural resident, it can be difficult for them or their caregivers to access health care or other services because the hospital did close due to financial instability. A lot of the policy governing how much money comes from the federal and state government to hospitals is really geared toward models that work well in urban centers and have worked miserably in rural areas. So there's been a steady drop-off of the number of rural health programs around America. There are fewer housing, education, employment, and transportation options in rural America. Greater geographic and distance barriers. Just imagine, you might have to go 300 miles in Montana to get to your health facility. Higher uninsured rates in general, difficulty of safely aging in place in rural America. You know, it's a wonderful bucolic image of being on the farm and rocking on the back porch. And that's really a nice image. And I think it could be a really nice life. But if you're running into health problems, it's going to be a little hard to get off the front porch and get to a healthcare provider. The VA currently allocates 32% of its entire healthcare budget to rural veterans. However, veterans do represent 40% of all enrolled veterans. So it's a good question as to whether they're still getting their full share. Some other challenges. Rural veterans enrolled in VA healthcare are significantly older, and we hear that rural Americans are older. 55% of rural veterans enrolled in VA are 65 or above. And again, as Mark alluded to, their health needs are much more intense and frequent. They're more likely than the average veteran to be diagnosed with diabetes, obesity, high blood pressure, heart conditions, that require more frequent, ongoing, and costly care. And you go recognize that, COVID has certainly brought attention to the fact that these are the chronic diseases of the poor. 26% do not access the internet at home, which is a major problem because, like all healthcare, VA has put a lot of stock in telehealth and has done remarkable things. And VA has been the leader in telehealth for some time. But if you can't access the internet at home, telehealth isn't going to help you a lot. Rural Americans are more likely to suffer from mental health problems, including substance use. I always like to point that out because many people don't lump substance use under mental health, but it is a mental health problem. And I want to be clear that I'm framing it that way. The suicide rate for all rural Americans is 1.5 times the rate for the average American, which is roughly the same, increase as for all veterans. I've never seen a study that shows whether rural veterans are more likely to die by suicide than other veterans. It would be a good study to do. Isolation and higher rates of access to firearms, as Mark mentioned, may be factors in this. Rural counties have fewer psychiatrists and psychologists, and in some states, more than 50% of the counties do not have a psychiatrist or a psychologist. 98 rural hospitals closed between 2010 and 2019, and that's actually, I think, an accelerating problem in America. A really nice study was done for the West Virginia legislature back in 2008. And I know that's sounding old now, but there haven't been a lot of these studies, and this was a very well done one out of the University of West Virginia. And it showed that 56% of rural veterans in West Virginia screened positive for either PTSD and or depression, major depression. These are just screening tools, but they're pretty good screening tools. That's a significantly higher rate than urban veterans in West Virginia, which is only 32%. So it's approaching twice as many. And that may reflect findings of a higher combat exposure among rural veterans. Native Americans serve at the highest rate of any ethnic group in America. They also have the highest rate of combat exposure. And the National Vietnam Veteran Readjustment Study, it turned out that Native Americans had a higher rate of PTSD, but it was commensurate with their higher rate of combat exposure. It's true for Blacks too. So there are subgroups of the American culture that get more combat exposure, and rural are among them. Rural veterans with PTSD and depression also reported lower levels of function in every domain measured. And it's worth noting that rural veterans who had PTSD or depression had lower functional scores than those with PTSD or depression, but they also had lower functional scores than urban veterans who had PTSD or depression. So they seem to be, really behind. And could this represent social simulation, access to care? I want to point out also something that's important. If you go to rural communities in North Carolina, Virginia, West Virginia, very high uptake of people who belong to the Guard or Reserve. And just as Mark said, healthcare is one of the big employers in these communities. The National Guard is one of the big employers. It's one of the few ways to get a steady income supplement to your family if the factory is closed, if Walmart is closed your grocery store and you don't have a job anymore. So we see a lot of Guard and Reserve members. What's really important to remember is a lot of local communities and even the large urban medical centers that serve those local communities as hubs don't accept TRICARE because they say, I'm 500 miles from the nearest military facility. Why would I possibly want to bother with TRICARE when in fact they're surrounded by Guard and Reserve members at a higher rate often than the 100 miles surrounding the military facility? But they just don't know it and they don't get it, partly because they don't ask veterans, their patients if they are veterans, which leads us to a study we did in VA in 2011, also showing its age, where we found that rural providers, this was a convenient sample, but it was a pretty large sample mostly in South Carolina, North Carolina, and Virginia. Rural providers were significantly more likely to be primary care professionals rather than mental health specialists. And this is important to point out too. Mark mentioned, there's primary care, there's mental health. In the VA, every primary care clinic includes mental health assets embedded. Not true in most of the world. And you have to kind of remember that's, if you're used to VA, that's not what you've got in the community. It's certainly not what you get in rural health. While rural providers were equally likely to have served in the military as non-rural providers, they were significantly likely to have ever worked for VA. And so they have less practical experience in the kind of issues that are present in military and VA populations. They also don't know the resources VA might provide if anybody wanted to ask about them. They have disparities in knowledge and confidence. And it's one thing to have clinical competence, it's another thing to feel confident that I can do this, that I know what I'm doing here. And doctors who don't know what they're doing often don't even ask the questions that would lead to trying to do it. That's just part of medical culture, certainly in my experience. So we ask questions about, do you feel competent? Do you have the knowledge, the skill, but do you feel confident in doing it? And a significantly smaller percentage of rural providers tell us that they even ask, have you or someone close to you served in the military? Only 37% of rural providers even ask the question versus almost half of non-rural providers. So that's already one hand tied behind your back, especially realizing that rural Americans are more likely to be veterans than urban Americans. Disparities in knowledge and confidence. Rural providers were significantly more likely to disagree that they were knowledgeable about best practices in treating depression, substance use, or dependence, or managing suicidality. Only 26% of rural providers disagreed with the statement that they felt knowledgeable about treating depression versus only 16% of non-rural. 26% disagreed with the statement they felt knowledgeable about treating substance use or dependent versus only 15% of non-rural. 37% disagreed with the statement they felt knowledgeable about managing suicide versus only 24% of non-rural. So there's definitely a lack in knowledge base as expressed by the clinicians themselves. There were no significant differences in professed knowledge about managing PTSD or traumatic brain injury, or for that matter, family stress and relationship problems, which are often issues for veterans. But rural providers were significantly less confident about treating PTSD than non-rural counterparts. 46%, nearly half, disagreed about feeling confident about dealing with PTSD versus only about a third of non-rural. Rural providers were less confident about treating depression, 26% versus 15%. Almost twice as many people disagreed with confidence about that. The same pattern held for confidence about managing suicide, 37% versus 24%. RAND actually built upon our 2011 study in VA and did it in the great RAND way, which I have tremendous respect for. They created a study called Ready to Serve. By the way, if anybody wants my slides with all the active links, I'll be glad to share them with you. Just, you can say in the chat or send me an email later. So RAND's Ready to Serve looked at community-based provider capacity to deliver culturally competent, quality mental health care to veterans and their families. This came out in 2014, and it was kind of replicated at the request of New York State a few years after that. So these things held up in New York State. Anyway, more recently, only 13% of all the surveyed civilian providers, and this was a really well-constructed survey, met all the readiness criteria to care for veterans. So 87% of providers using a good national sample would not meet these criteria to treat veterans for mental health issues. Providers who met the threshold for cultural competence, they knew something about the military and military life and the stresses that go with it, did not necessarily meet the other threshold for providing evidence-based care for those problems. Providers who work primarily in military or VA settings were significantly more likely to meet those criteria than those who never did. And these providers may not even be available in rural America in the first place, as Suzanne and Mark were saying before. It'd be great to say, well, we can train those people, we'll find the ones who are really good. Well, unfortunately, they're not there at all. So in a lot of these areas, as Mark's maps from HRSA show. In order to address these things, frankly, Congress and the VA have been very proactive. In 2006, Congress legislated that VA would create the Office of Rural Health. to target research programs, research clinical programs, and new models of care for rural veterans. And each VISN, each Veteran Integrated Service Network, has a designated rural health lead. I actually took that job on as a collateral for 4 years. I wonder, again, if you know your VISN rural health lead, it would be good to, you can actually search for them on the web and find them. And it's a good thing to meet them and know them. ORH funding was very generous. It started at $250 million a year. And building on that money and through trial and error, because you can't just throw money at problems. You need people who know what to do with the money. But knowing the money was there, it did in fact lead a lot of VA people, and me included, to get interested and get serious about, well, what could we do effectively if we had the money? And at this point, ORH has funded more than 1,700 rural health programs at local VAs and implemented several national initiatives. Funding is available for VA applicants in 2 types of programs. One is Rural Promising Practices. That's money to go right to the field. Another is enterprise-wide initiative. Say the Office of Women Health, the Office of Mental Health decides, the folks working with opioid crisis decide that they have a rural plan they want to do out of their program office. They can ask for this money. ORH, probably as well or better than any other office in VA, figures out who's good at this stuff and gets the money to them. They're extremely good to work with. And I recommend that you folks take a look at their website and reach out to them. Here's an example of some of the things they've been doing. At the VISN level, they help fund telemental health resource hubs across all specialties, including primary care, which is a kind of specialty in itself. So the VISN telemental health hubs were partly built with rural health money from ORH. They created this wonderful community clergy training local community clergy leaders and lay leaders to identify service members, veterans, and their families in their congregations and know how to triage, not to become mental health professionals. How do you identify them, and how do you point them toward the right resources within VA and other resources for veterans in the community? Military sexual trauma web-based therapy, rural suicide prevention programs, rural social workers who are members of patient PAC teams or primary care teams in VA. The Vets Prevail web-based behavioral support program for veterans with PTSD or depression in rural areas. That's just a tiny sampling of what they're doing. I want you to know, those of you who are not with VA, to know there are opportunities for rural health partnerships with the Office of Rural Health. It focuses on collaboration with federal, state, and local entities to increase rural veterans' access to care and support their health and well-being. These partnerships optimize the use of technologies. They leverage available resources, establish new points of access. And point of access, as rural health people have taught me, if you're thinking rural health is a small town, you're wrong. Rural health is often a crossroads. It's the farm where other farmers get together to talk about politics, the weather, and problems in the community. It's the barn where people show up after a hurricane goes through and people figure out, what are we going to do? Rural health is not just small towns. It goes well beyond that. So figuring out, how do you get access at those places? How do you connect with those people that gather at those places? Because that's rural America. That's mental health. It involves transportation. One of the biggest barriers we find to VA access is transportation, and that much harder in rural. As Mark mentioned, weather. It could be a beautiful day to drive across the mountains in West Virginia, but if it snowed, it's not such a good day, and that distance is not what it was before it snowed. Provider shortages we've talked about. Scan Echo. A lot of folks who know rural health know about the ECHO program, which started at the University of New Mexico, right? To reach out through the renal system. They were getting, what happened with the impatience of a renal specialist in Albuquerque. He said, I'm sick and tired of renal consults that are not worth doing. And these patients travel, hundreds of miles sometimes to meet with me, and they don't need a specialist. But the local doctor didn't feel confident. So he started creating these online consultation workshops with some lectures, some case presentations, but mostly creating an online community of primary care docs and specialists in renal who would then get much more confident, and suddenly they weren't getting all these inappropriate consults. Their kid, the renal specialist could see people who needed a renal specialist, and these patients didn't have to travel hundreds of miles, spend money on hotels and gasoline that they didn't need to do. Well, VA picked up on that and created Scan Echo. And through that, we partner with community partners, with small VA facilities, provide training, education, and also to learn about their problems and find ways to respond to them. And finally, the whole question of the social determinants of health, housing, education, employment, the strength of a tribal community or any rural community, because as we know, the social determinants of health account for 80% of all health outcomes, much more than medicine. So I want to leave you with this idea that if you have ideas about how to partner, or that you might even want to think about how to partner on initiatives or projects to reduce barriers to care for rural veterans and expand access to care and services, you would reach out to the Office of Rural Health. And there's their email address and there's their phone number, and it's on their website. So I'll stop there. And I know I probably already talked more than I meant to, but thank you.
Thank you so much, Harold. That was just amazing. So much, we could talk about this for hours. And I think we may actually end up going over because Don is going to present, and so I really would like to have time for questions. And so I think probably we'll go over our 12 o'clock if folks want to hang around for questions. But I want to turn it over to Don Kolish, and he will give a personal perspective, I think, particularly of what it's like to deliver rural healthcare.
Well, thanks, Suzanne, and thanks, VHPI. Actually, with some luck, I'm actually going to talk a little bit less. I only have a couple of slides, and hopefully I'll leave plenty of time to talk. Although I've spent a little bit of time in academia doing some research and teaching, most of my identity is as a community doc. I practice in rural northern New Hampshire, and then I ended up returning to work for the VA, both at the Vermont Medical Center, but then at a rural community-based outpatient clinic. And it's going to be interesting. You talk to 3 doctors, you'll get 5 opinions. Among the things that I'm going to do is I'm going to disagree with Mark and Harold about a couple of things. But one of the things that I do agree with is that rural areas are underserved. And can everybody see my my arrow? Is that okay? All this up here, that's Canada. So northern Vermont, northern New Hampshire, northern Maine, and the yellow has a lot more detail in it perhaps than I'm going to be able to talk about. But these are the health profession shortage areas, and where I used to practice that was my turf for quite a while, and so the challenges of bringing doctors, primary care doctors and specialists alike to rural areas, it requires all of the skills that Mark and Harold can muster. So what's some of the good news? Because we've been hearing actually from Mark some of the challenges. I think from Harold we also saw some challenges, and I guess my experience with primary care docs in rural areas runs counter to Harold's data, and that is I thought most of them were pretty darn confident, that they sort of had to be confident to be working in frontier areas, and so they did have a lot of both competence and confidence at taking on many of the issues that Harold mentioned, the depression, anxiety, PTSD. But the VA does somewhere between a very good and excellent job of placing clinics out in the rural areas. It is not just the VA Medical Center, but the CBOX, and anybody who's who's been in the service know that we love acronyms. So the CBOCs provide primary care, they provide mental health and physical therapy, eye care. Most importantly, in today's world, particularly during COVID, they have telehealth suites, and so that rural vets did not have to go all the way to the VA medical center, which in Vermont maybe is a 2.5-hour drive from the far northern Vermont, but they only had to make it to the CBOCs in Newport, Vermont, and Littleton, New Hampshire, where there's a telehealth suite for them to connect with the specialists at the VA for specialized services. And in general, the civilian doctors also were an excellent resource for the vets. There's not enough of the civilian docs, but they knew that the veterans were an important part of the community. They were at that barn that Harold mentioned, and they were on the fire department, as Mark mentioned, and they were proud of the fact that they are proud of the fact that rural communities, that people in rural communities, including, I know there was somebody in the chat, a member of the Navajo Nation, and as Harold mentioned, the Native American communities in particular enlist at higher rates than urban areas. But I also found in some of the training programs that I had the privilege to work on that that civilian doctors were more than willing to learn about this thing, I don't know if you can see that, but we have sort of a program about training civilian doctors to ask, have you served? And that they were very proud to learn more about combat-related PTSD in particular. The take-home, and then Suzanne, I think we will have plenty of time for questions, is that the VA remains the foundation of care for rural vets. That the VA has a system, and believe me, as an employee of the VA, I know about the bureaucracy. It can make you crazy, but there is a thoughtful and functioning system of outreach and of referrals, including transportation, to get vets to where they need to go. The civilian systems of rural healthcare are very supportive of care for veterans. But finally, that the civilian system does not have great excess capacity in rural areas. I'm thinking about the map that Mark showed, and the civilian system, which maybe has a lot of docs in those white areas on the Colorado map, does not have a lot of docs out in the blue and light blue areas. So the civilian system does not have great excess capacity to absorb vets via either the choice or mission programs. As a former rural VA doctor and as a former rural civilian doctor, I can say that rural America needs both.
Thank you, Don. So I'd like to open it up for questions, and I guess you can. Wow, how do we do this, Jasper? We put it in the chat or raise your hand. So Rick Stagenberg has his hand raised. Rick?
Yeah, I had a question about telehealth. With the infrastructure bill providing $65 billion to expand broadband, does anybody have a sense of how much that will affect the VA's ability to get services to these 25% of veterans who currently don't have access to telehealth?
Do you want to take that?
It ought to help. It ought to help a great deal. But the challenge is just so big. I mean, even here in North Carolina, in suburban neighborhoods, there are neighborhoods where kids had to go to school who couldn't do their homework because they couldn't get the internet, had to go park, in the parking lot from the local library to get signal. And when you think about West Virginia, I spent a lot of time in those hills. It is so hard to get down into those little coves and valleys that frankly don't get sunlight a lot of the day because they're so steep on both sides. It's going to take all that money and more to get it done, but it's going to help, no question about it.
We have Gregory Jones.
Yes, good morning, and thank you for the opportunity to raise just a couple of quick questions. Hopefully I won't bore the rest of the group, but here's the question. Number one, if what we're reading about the impact of COVID on the delivery system, particularly nurses in those institutions, and I'm calling from Madison, Wisconsin, is having an effect on service delivery, is that same trend existing or exacerbated in those care facilities that provide care for veterans? And then lastly, you three are coming from different sections of the country, nothing from the Midwest. Do you think the trend data that you described on the population is similar in the Midwest?
I'm going to take the nurse question because I'm a bit of a specialist on nursing issues. The nursing, there's long been a nursing shortage. It's now a crisis, has turned into a catastrophe. And the VA is losing nurses because of cumbersome hiring processes, but also because it can't compete with the private sector in pay. And I have just talked to a number of folks in VAs around the country just in the past few days, and they're hemorrhaging nurses because these hospitals that have lost nurses like Yale New Haven or whatever are paying massive hiring bonuses and so forth. And the VA there is legislation to, there's some folks on the call that might be able to speak to this, to increase nurse and physician pay. And it's really necessary because this is probably the worst hiring environment in the history of the VA for nursing because of the competition and shortages in the private sector. And the other thing I do want to point out about nursing and physician assistants is they were expected to sort of, I don't know, altruistically volunteer to go to rural areas and urban areas where there wasn't as much compensation, and that has not turned out to be the case. Your second question, I think maybe Mark, maybe you want to take that about the Midwest.
So was the question about VA access in the Midwest or general access? Can you clarify?
VA access for rural, as you all were talking about the rural veterans, what's the trend line there?
Sorry, I don't have any information on that.
I'd like to recommend, though, that if you go to the ORH website within VA, there are actually regional rural health centers that drill down to this stuff and could help you. In addition, another place in VA you can go look is the VISN 16 MIREC. I know, the Veterans Integrated Service Network, Mental Illness Research Education Clinical Center. I'll put it in the chat. And they have a rural health specialty. And they can tell you something about VA rural health around the country. I think they may be able to give you more on that.
Final thing, Greg, I'm just going to send you also a link to these HRSA maps that Suzanne published earlier, and they give a really general sense of how Wisconsin's doing. So if you just click that link and type in Wisconsin, you can see sort of the general healthcare environment in those rural areas. So I'm just going to send that to you now.
Teresa Morris.
Actually, let me just say one quick thing, Suzanne. Not often recognized is what's called the fourth mission of the VA, which is to provide help to the civilian world. And Mr. Jones, you mentioned, wondering what happened, particularly with COVID. The VA, and I know this is true because for Madison, because I have some friends there, that VA docs from in Madison deployed to rural areas and other places in Wisconsin to help provide services, which sort of tells me that both that there was an access shortage and that the VA was part of the problem, part of the solution.
I want to recognize Teresa Morris.
Hi, everybody. I'm Teresa Morris. I'm with the Nurses Organization of Veterans Affairs. I just want to mention, to actually piggyback on what Suzanne was saying about nursing shortages. So we've been advocating very strongly and help get HR 5575 introduced, which is the pay cap bill. So what it will do will provide an increase for RNs, NPs, PAs, CRNAs, and podiatrists on, within the executive scales, the executive schedule, I should say. So we're, really hoping. There's obviously been a little bit of pushback on the Republican side, but my understanding is that the Senate VA committee folks are highly supportive. The secretary's spoken to it during his 10-point, I want to say it was a 10-point workforce press conference he had maybe 2 weeks ago, if I'm saying that correctly. I also have heard that Senator Tester's working on some workforce legislation. So we're hoping that that's going to help. Obviously, VA can't be a pay leader in most communities. So that is always going to be an issue in terms of being able to offer large bonuses and that sort of thing. But I'm working with staff on some other things that I'm hoping that will alleviate. And also on the rural shortages. During COVID, we've, at least I know this from some of NOVA's membership that obviously are all VA nurses. Some folks were moved out to help in New Mexico, actually in the tribal communities and other rural areas, but that was during COVID when there were surges. There's still been a little bit, not currently, but I'd say 6 months ago, I had a couple members that got moved to areas that were having surges from other areas that were calming down a bit. So that's probably not exactly what y'all were referring to, but I did see some movement among some of the nurses in different areas to, rural areas. Thanks.
I'd also like to add that if someone, for example, is in the Guard and gets called up to leave one area and go to another, that's going to leave a deficit where they came from. So it really is sort of robbing Peter to pay Paul situation.
Thank you. Tammy Bartlett, you had a question. Do you want to raise it to the group?
Sure, I just wanted to get their input on used to be called Project Atlas, but now it's just Atlas. It's a pilot program that was run with VA, Philips, Walmart, Legion, and VFW. VFW has all 5 sites up and running. I think Legion has 3 or 4, and Walmart is also working on their 5. So I just wanted to hear back from those who presented, what their views are. Have they heard of the program? And do they think it's something good to go forward with?
Harold, do you know anything about it?
I think it must have come on the scene after I left VA central office in 2018. Maybe Don has some experience with it.
Sorry, no. Tammy, I look forward to hearing more about it. Can you post a link in the chat and we'll take a look?
Yeah, absolutely.
Tammy,
Sure, will do.
were these sort of the booths that were available for vets to do secure telehealth at like Legion posts and things like that?
Correct.
Yeah.
Philips has created these pods, exactly like you said, secured appointments within these booths.
No, that's terrific. And what we need are more templates to create public-private partnerships, just as you're describing. One of the biggest barriers used to be that people would say, the VA would say, I'm not sure it's confidential enough where you are for a veteran to be talking on a telehealth machine. What if people over here in the hall, are the hallways wide enough to let a wheelchair get down or a stretcher? And, they try to apply VA hospital standards to, say, a veteran service office on an Indian reservation. And this gets in the way. But the fact is that the VA has learned to create some new templates and improve. And by the way, there is a VA Office of Public-Private Partnership that can also make these things move.
I think that unless there are other questions, I just want to conclude, and I want to leave you with some suggestions. Harold, you talked about public-private partnerships, and I think it's really important to have public-private partnerships, but I think that the public-private partnership has to be a partnership in which the private doesn't steal from the public, but rather helps the public. And often, in my view, what has been supported are public-private partnerships that do the same. And I think that sadly, some of the recommendations of the secretary for closures and facility changes will do that. They will, really rob the public to profit the private. And that doesn't help veterans. There was a recent study that we have written about, a study that was published just the other week in the British Medical Journal, which showed that veterans who are Medicare eligible and VA eligible who go to private sector ERs are twice as likely to die in the ER in a private sector hospital, and it costs the public more than 21%, to 21% higher. I think that we can't afford in America the closure of another rural hospital, yet some will be closed, another rural CBOC, another rural access point. There simply are not enough, as I think everybody here has emphasized, there just are not enough folks in rural America or even urban America to absorb veterans. The capacity doesn't exist. I think also that, as Harold has pointed out, and as the RAND studies have documented, we can't confuse willingness and good feelings toward veterans with knowledge to treat veterans. And the RAND study, Ready or Not, which looked at New York State, showed that when they developed 7 criteria for competence and capacity to treat veterans, and they surveyed private sector providers, 2% of those providers had the qualifications, yet all of those providers said they wanted to do their bit to help vets. We love vets. But then the vast majority of those providers who love vets and are happy to take taxpayer money said they didn't know anything about veterans, and they also wouldn't take the time to learn. We have a system that is a work in progress, but that has established expertise over decades to care for veterans. We need to partner with the public, and with the private, but we need partnerships that have the veteran and the caregiver at their center. And so I think we have a lot on our plates. I'm so excited that we've done this Zoom. I think we will give you more information. We will post something on our website with all these links. And I think that the commitment of the folks on this call is staggering. The years of experience are staggering. And I know that we all have the same goal, which is not just to fulfill the mission of the VA to care for veterans, but to help all Americans, whether with research, teaching, or in a national emergency. And we certainly hope the VA doesn't add to the emergency. So thank you so much. And we'll be in touch. We'd like to encourage everybody on this call to go to the Veterans Healthcare Policy Institute website, which is veteranspolicy.org, to subscribe to our newsletter and to check out the work that we're doing and the ongoing work that we're doing. If you'd like to donate, we're thrilled. We really value your coming to this, and we look forward to more Zoom forums that deal with critical issues that will be coming up in the future. So thank you so much.
Thanks, everybody. Thanks for coming.